Hello, everybody. Sorry for the delay in starting. We are so excited. You are not going to be disappointed that you waited. We have some wonderful panelists today to talk about achieving equity. Um, I'm Jody Anthony. I'm a principal associate at App Global with a primary focus on health equity. And we are joined today by Jody Charles, who is the equity team leader at the Office of Health Systems at USAID, Phyllis Height, who's the founder of the Missing Billion Initiative, and Miguel Pulido, who's APP's Chief of Party Local Health System Sustainability Project in Colombia. Before we dive in, I want to let all of you know that you can post questions in the chat and I will do my best to get to them in this hour. So first, I'd like to set the stage with just a little bit of framing. And I think it's important to note that this webinar is the fifth in this series. And if you have a chance, if you haven't participated already, I highly suggest you go to our website and listen to them. They're really informative. But what you'll notice is that each one of them has discussed inclusion of community members in one way or another. In the one about primary health care, panelists discussed the importance of walking hand in hand with communities. The second webinar focused on localization and how local actors must co-design, co-implement, and co-evaluate investments. The quality of care webinar, we had a panelist describe the People's Voice survey, which asked community members across the globe whether the system's working for them. And it's really starting to bring measurement and data into inclusion. So inclusion as an essential process for achieving equitable outcomes has been woven throughout the series, but today we get to dig deeper and discuss the how of engaging community members, the for what purpose community members are engaged, and the ever important question, how do we know we're having these? So I'm going to turn to the panelists and I'm going to ask each of you a broad question to help participants understand your perspective and your work in equity. And Jody, I'm going to start with you. Hi, Jody. You are the equity team leader within USAID's Office of Health Systems, and it includes equity as an important outcome of health system strengthening. Can you describe a bit how you promote equity as a health systems issue?
Sure, yeah, and I think this is the first time I've been on a panel with another Jody, whose name is spelled exactly like mine.
Yes,
So,
and we're both from the Midwest.
Welcome to the the club, or welcome me to the club. Hopefully, I won't get too confused. Yeah, so I think we approach equity really from an implementation standpoint. So we like to utilize a complex adaptive systems approach. And we're trying to address inequitable access to and quality of, primary healthcare services. So a guiding principle for us is that, health systems are equitable when everyone has a fair opportunity to attain their highest health goal, regardless of their status. So it's not about equality, it's about equity. And there's a key difference there. We really just want to make sure there's a level sort of playing field, so to speak, when people go to access their care. We want to focus on, from a health systems perspective, we want to focus on the underlying systems issues and those root causes that impede equity, and identify approaches that are going to work in specific contexts and specific country, and really are engaging the right local partners and meeting the local priorities. We also want to take it from sort of high concept. We see equity as a high level goal, which is perfect. It should be, but we also want to take it from high concept to concrete. So ensuring that when we're talking about implementing things that are, supposed to move the needle on equity, that it's robust, it's focused, it's a deliberate approach, and it's evidence driven. We also want to challenge assumptions on effectiveness and efficiency, for example. So when we're talking about universal health care, primary health care, community health, one of our key priorities is that we really want to approach equity in a way that is efficient and effective is reaching the right populations and are addressing some of these sort of I wouldn't call them necessarily like myth busters, but we need to sort of unpack this a little bit. When we call something equity or pro equity, is it really equity? So a couple of these examples is that access, in my mind, access and equity are two sides of the same coin, but they're not exactly the same thing, right? So access, whether we intend to or not, when we're talking about access, we're often talking about building the system out so that people have the services available to them much more from a supply side perspective. So, what that's not necessarily the case, right? If you build it, they may not access it. If you provide a service, people are not necessarily going to be uptake of services. So why is that? And really looking at it from the client side, client-centered approaches. Another sort of myth busting thing is that people often think when they talk about equitable approaches, it's going to be this big, expansive, scaled up approach. Everybody has to be involved in everything, and that the unit cost then is going to be driven up dramatically and unsustainably, particularly as we get more to the last mile. It's not that that's doesn't happen, but that's not sort of a blanket statement. It's not necessarily always the case that it's going to be overly complicated or overly expensive, right? And so we want to talk about how we're going to achieve equity goals in a way that are cost effective, cost efficient, and not really look at these as a zero sum game with overly complex processes and high unit costs. So we do have a range of approaches and activities that we have been utilizing around things like social behavior change or behavioral approaches, and really looking at what's driving behavior, and why people are accessing or not accessing in a particular population. And this is really important to dig in on this as a critical area. Looking at things from a political economy perspective, what's going on in this complex adaptive system that is creating an environment, that's pressing down on the environment in certain ways. What are the sort of hydraulics at play there? And then more specifically, within that, looking at things like community health and healthcare workers and, what do financing arrangements look like? So starting kind of high concept, but then slowly getting down to sort of context specific factors, and then taking that the next level down when we're talking about what does a specific intervention look like, or are we talking about healthcare workers, are we talking about financing, or what is the outcome that we're looking at? But it's sort of slowly layering different levels of the system to sort of make sure that we're working in a way that really is moving the needle on equity. And I'll stop there.
That's great, Jody. Phyllis, I'd like to turn to you. You have been a leading voice on the issue of improved health and access to health care for people with disabilities. And I wonder if you can talk a bit about how you approach equity as a systems issue, and in particular about the scale of the problem when health systems are not inclusive.
Thank you very much, Jody, Jody A, and thank you for the invitation to this webinar. I'm actually a global health person, a health systems person, a health economist, but when I learned about the health inequities that people with disabilities experience in the health sector, I decided to start the Missing Billion Initiative with colleagues, because I think it's one of the most white spaces and biggest injustices in healthcare that very few people are talking about and working on. So I'm thrilled that I can tell you a little bit about it. And so to pick up on the question around scale, and to talk a little bit about this to set the context. There are around 1.3 billion people living with disabilities worldwide. And people with disabilities, some of them have particular specialist healthcare needs, such as, for instance, an assistive device. But all people with disabilities have general healthcare needs like anybody else. However, for a range of reasons, these healthcare needs tend to be higher on average than for the general population. Now, despite that, their healthcare access is significantly disadvantaged. They face issues from healthcare workers, inaccessible clinics, insufficient awareness, unaffordable healthcare. So all of this together leads to significantly worse health outcomes. And this is across countries, so that's a worldwide issue. This is across diseases. And we've shown in the Missing Billion reports from 2019 and 2023, you're welcome to access them on our webpage, that these health outcomes really are systemic and altogether will prevent achievement of any global health goal and SDG 3 overall together. And this is because there are 1.3 billion people with disabilities. And when you have HIV rates that are 2 to 4 times higher, or childhood mortality rates that are a multiplier higher than for the general population, then it is clear that these outcomes or these goals are not attainable. And that's, of course, an issue for us as global health people, but that's also a human rights breach and injustice that we obviously really need to work on. As I mentioned, it is a systemic issue. There are system level factors at Ministry of Health and funder leadership that lead to service delivery being insufficient and inaccessible. And yeah, if we want to solve this issue, first of all, obviously we need to all learn about it, talk about it, but then apply a systems change approach and address all levels of the healthcare system and of a healthcare framework to solve it.
Thank you, Phyllis. And I'm going to turn to you, Miguel. Your work takes on another aspect of equity in terms of ensuring that Venezuelan migrants are included in Colombia's health system. And so while Jody has described the importance of equity in health systems, and Phyllis has reminded us of the intense scale of the issue, I wonder if you could talk a bit about how even with Can everyone hear me okay? Is it sounding a little better? Okay. How even with recognition of the importance and scale of the issue, it manifests differently depending on different locals.
No, thank you for the question. I am glad to be here because in Colombia, since 2016, more or less, Colombia was considered an immigration country rather than a host country. Colombia was traditionally seen as a country that people left. However, due to the socioeconomic crisis in Venezuela around 2017, Colombia transitioned into a receiving country for migrants and refugee populations. However, even before the migration impact, is Colombian territory faced their own challenges. Therefore, the migration effect had different impact in each territory. For example, in small cities, the impact for migrants and refugee population was superior compared to other cities. And this thing put the national and the local government to adjust their legislation to assist, attain, and welcome the new incoming population. It was more or less so far is 2.7 million Venezuelan migrants living in Colombia. The other point was the territorialization process of these public policies, because it wasn't easy. You know, it's not only to generate a decree or any legislation at the national level. We have to implement that, and some territories don't have or didn't have at that moment the capacity to implement these things, especially in small towns. The big challenges also translate into financial barriers. For instance, if municipality or small town decides to expedite the process to incorporate them in the insurance or monitoring migration populations to get access to the health service, they didn't have the personnel, the technology, and that really become in a lot of problems in each of these territories. But the challenge was to overcome, create mechanisms to give the opportunity to things that they didn't do before. This is more or less the situation that we were facing here.
So my next question actually echoes a little bit about the first question that we see in the chat, which is that at ACT, we talk about equity as both a process and an outcome. The process is about promoting practices, relationship, and group dynamics that create more equitable conditions for staff and interested parties and those experiencing the inequities. And by working in an equitable process, or working in an equitable way in that process level, we're more likely to achieve equitable outcomes. And so I just want to first start with Phyllis and ask if you could reflect on the different stakeholder or interested parties that need to be included as part of the process of achieving equity within health systems.
Yeah, for sure. And I get a signal that my connection is unstable, so please give me a sign if I don't come through clearly.
You're good.
You know, there are the stewards of. Can you hear me?
Yes.
I would say it starts with ministries of health. They are the stewards of healthcare systems, and it's critically important that within Ministry of Health structures, there's roles and responsibilities on disability inclusion, and that ultimately national health sector plans have a disability lens and pick up on the disparities that persons with disabilities experience and that lead to worse health outcomes. So that's a very important stakeholder group, and the Missing Billion Initiative, for instance, has developed a health system level assessment for ministries of health to apply, understand the status quo and disability inclusion in their country, and to understand what tangible actions could be to improve the current situation. Second, I would say is funders for those countries that rely on external financing. We see that the majority of health funders doesn't yet have any expertise or really lens on disabilities. Most of the funders that's a very powerful dimension, of course, if funders request for grantees to be disability inclusive and to understand if the desired programming reaches persons with disabilities as well, then a lot of action and impact can be had with that. Then thirdly, there's implementers and providers of healthcare services. Of course, that's where the actual service delivery happens, and healthcare workers need to be trained about disabilities. Facilities need to be accessible. The financing needs to be affordable. So a lot of those things can be influenced by providers, whether it's for-profit or non-for-profit, and technical assistance providers. So I'm hoping that maybe I can collaborate as a result of this webinar with a lot of the APT colleagues who do such important work across so many countries in technical assistance capacity. And there's tremendous opportunities to include a disability dimension in that. And then lastly, and most importantly for this work, there's of course the participation of persons with disabilities themselves in this work. As of today, there isn't strong participation of persons with disabilities in most health sector coordination structures, and the voice that we see from some advocacy groups isn't just there yet. So an important part of the work with the system that they're really at the forefront of helping design and inform how healthcare systems need to look like so that they're inclusive for persons with disabilities. With the Missing Billion Initiative, we also try and live that. So as of today, around half of the staff are also individuals who are health systems experts or academics working in this field, but also happen to live with a disability. So that is, I would say, one of the most important the most important stakeholders, and one that's very often not included.
Thanks, Phyllis. And just as a follow-up, I'm curious whether there are some bright spots about how to engage people with disabilities in program planning, implementation, evaluation. You mentioned so a challenge, and I just wondered if there are some things that you can point to or tips for those ones.
Well, most countries have established organizations of people with the regional level, and then they all come together. Participation, it is a good strategy to approach how individuals can be involved in the program design or in the how in the program. In doubt, always go to the
Sorry, Phyllis, you're going in and out. I'm wondering if you should come off, if you should maybe stop your video. I think maybe that will help with your with internet access. I think we missed a little bit of when in doubt. You had suggested a final, I think it was a resource maybe. Okay, well, why don't we put that on hold while Phyllis is working out her connectivity issues, but it sounds like my volume is difficult to hear as well. So I don't know, maybe it's a Wednesday morning, 9 a.m. Eastern challenge we're all having. So please bear with us. I'm going to next ask Miguel. So just because all stakeholders are included in your various efforts does not mean they're all going to be on the same page. And I think in particular, you can share some of the challenges that you've had to overcome. And you know, how do you help overcome those differences of opinion and other challenges? And how do you make sure the underrepresented voices are heard?
Absolutely, that is a bit a challenge. Here is important. We work as a team here in Colombia to face that thing. We work as a team with a crystal clear information, you know, in a public-private partnership, and super important. Don't generate false expectation to any actor. You know, that's very important. At the other point, mutual respect. You know, that is also an key factor that have been successful here in the implementation of our activity. We work with a goal to co-create relationships between the Minister of Health, territorial entities, the private sector, the international cooperation, the community-based organization, and other key stakeholders that we can identify in each territory. It is not a magic formula or recipe. Each territory or each project or activity need an adaptation and an identification for the needs and opportunities. You know, it's crucial to recognize the particularities and possibilities of each territorial entity in its fiscal things, technical, institutional needs, capacities, and requirements. Our activity here in Colombia promotes informed and sustainable decision-making through the co-creation of a clear relationship between any of our strategies. And this, this relation, this strategy establish a specific goal and objectives since the beginning, identifying as I said before, the relevant actors and define the roles and responsibilities of each. If we have clear role and responsibility, is a key of success as well. We have here promote and create necessary actions. Is not only, as you said before, it's not only to create the access with quality, access with from the migrant population, Colombian returnees and host population at the same level. We create any difference or VIP access is everybody has to be treated and get the access to a quality healthcare system. It doesn't matter if they are migrants, Colombian returnees, or host population. Let me give you an example here in Colombia. This activity advocacy is called a performance-based contract in one city called Barranquilla, where we co-create with the public, government, private organization to finance a package of prenatal health services for around 300 pregnant women from Venezuela with irregular migration status. In this city, we have been provided by a healthcare provider, and we are working as a team, the government, the health provider, the community-based organization, the Minister of Health, to optimize resources, financial resources, but create this package to have access and increase the early detection and mitigation of pregnancy-related risks. And we are expecting that this will be served as a reference model, demonstrating that this potential engaged to collaborate between all the private and public key actors. And that's important. With this example, we have clear communication. We don't have a expectation goal, different things. And we are working on the same page, everybody. And I think that would be prevent all this misunderstanding or this kind of problems between the different actors or stakeholders.
Thank you for that. And so turning to Jody, and you mentioned this when you were first talking, but even if we build equitable processes, we might not always achieve equitable outcomes. And so I'm wondering if you have any good examples from your work that have shown those linkages of equity in process and how that has been able to at least contribute to equity as an outcome.
Yeah, and that's an excellent question. And I don't want to wax philosophical too much here, but let me start out by saying that if the processes you've designed are not moving us towards more equitable outcomes, then I don't think your processes are really going to be equitable, right? You might have organized a workshop and brought everybody in the room, but I think the question that Miguel just answered and the examples that he gave about, just getting everybody in a room doesn't mean that that's an equitable process. It's how you engage them and what you do with the information that they gave, right? So I think it's an excellent question. It's an excellent way to frame it. And I think it really is a good way to push ourselves to say, are we really achieving equity with what we're labeling as an equity approach or pro-equity approach? And part of that is because I think we look at the input level. We kind of, we like in public health, proximal, causal, linear relationships. And when we work and live in complex adaptive systems, we can't always stay in that environment, right? There's a bigger question that goes beyond specific inputs or one single indicator. It's about looking at the system as a whole from 360 degrees. So if we've designed the processes right, then theoretically they would lead to more equitable outcomes. And if you're not seeing those outcomes, then you have to really question whether or not you have an equitable process. I think, when we, one of the things we try to do is look at when something, for example, is labeled pro-poor, if a health financing intervention or a benefits package is pro-poor, really, how are you achieving that label? What evidence are you using? What were the decisions made, and how were those processes utilized? So a couple of specific examples. I had mentioned social behavior change and behavioral approaches, including behavioral economics and SBC, as being something that we look at in the Bureau very as a critical approach. But we often label things as SBC that maybe are not as complete as they could be. It doesn't mean that they're not useful, they're not good, but there are a lot of things that we engage as social behavior change when in fact, what we're doing is probably more like awareness raising or information and education. Those are all incredibly important. I would never suggest that we not be doing those things. But I think it's important to look at, look at those approaches more robustly, more critically, to understand, are we really looking at it from the perspective of the people that are coming in, or that we want to come in to get services, or whatever the health behavior is that we want? And are we really addressing them? I think Phyllis, bringing up the people with disabilities, I think is really critical, because, we often think in infectious disease, it's like, oh, we need, people with disabilities are a vulnerable group. But there are also people who need routine health services, and it's not necessarily, it's not necessarily like just a unique set of services that they need, or a unique way of getting those services. But we really need to query that population, and also recognize that's not a singular population. There's a whole range of things, and it doesn't necessarily have to be big, some big expensive extra intervention. So are we really truly being inclusive and querying those populations and saying, well, what is it that's stopping you, right? In addition to behavioral SBC, things like respectful care, that's done a lot in maternal child health. We often, talk about how the care might not be respectful, but but what does that barrier look like? Understanding, what's stopping clients from coming in. Also looking at it from a provider behavior perspective. What are providers dealing with that's leading that behavior? Having a little bit of empathy on both sides, but also recognizing that, we're putting people in difficult positions. And we really need to address those root causes, whatever they are. The other example I would give is just around things like governance and inclusion and social accountability. Again, we often have these sort of participatory approaches in processes, but they're very often either time bound or sort of relegated to a specific part of the process. And I think, as Miguel and Phyllis have mentioned, if you're not really including them in the right areas, that if you're just doing a workshop and saying, tell us your opinion, and then you don't follow up on that, or they're not included further along the line, then did you really have an inclusive process? And that, just to caveat that doesn't mean that everyone is involved everywhere in everything all the time. It's making sure you have the right mix of people in the process at the right time. And again, just reverting back to Miguel's point about being very sensitive to that, and really being deliberate and thinking about how you're actually doing this and what makes sense in your context is critically important. And it's why there's not, everything has to be adapted to a specific context. It's not sort of an out of the box kind of a thing.
Thanks, Jody. I don't know, Phyllis or Miguel, any reflections on some of what Jody shared? Did it bring up any questions or thoughts about how you approach your work?
I want to start, sorry. As Judy said, this is not putting everyone on the same page can assure the impact of the results. But it's important to have a common goal and organize a agenda between all the key actors of stakeholders. We need to start to do things to achieve the optimal goal. I wanted to say that it's not just to hear the people, it's listening and taking consideration their opinions, and they can see the results, because otherwise we can lose important moments to get important ideas for the other actor. I completely agree with you, Judy. That's important, and when we are in these territories, we have to do that in different contexts of the different pressure, the political context or the local based organization. That's fact. That's important. But here in Colombia, let me finish my part in three parts. The first part, the systematic approach here in Colombia promotes a more effective and coordinate response involving multiple stakeholders to develop and join analysis and actions from the comprehensive perspective of the system. The strategies that facilitate the application of the systematic approach in Colombia were those that foster communication among health secretaries, community-based organization, national government, international cooperation, specifically with other USAID programs. We have to optimize resources and actions between the other programs, and LHSS Colombia start to work working with other USAID programs. In our case, strategies such as pause and reflection, discussing spaces among stakeholders, facilitate the process of mutual recognition and identification of collective solutions. That was a good practice, and lessons learned are shared and replicable in other territories. It's not only to show on this program, oh, we achieved this goal. No, lessons learned are important, and if we share with other key stakeholders, we can prevent mistakes or optimize resources. Second, on the other hand, there is the need to create a bridge between the community and the institutional structure, and with a clear methodology. Don't come in with a fancy terminology or something like that. We have to talk also in the same language. And in even here in Colombia, for example, even if Venezuelan migrants, this vulnerable population, speak Spanish, sometimes we don't have the same meaning for one word, and this is important. It is quite common to find this trust between institutions and the migrants and host populations because the language. We need to require the construction of these bridges to facilitate the communication for mutual understanding. And this is important to focus on strengthening community-based organization for this purpose and create this crystal clear communication. Finally, here, our activity, LHSS in Colombia, identified that it is important to have a pure capacity building process with community-based organization, tailored to their needs, preparing them for project execution and management, and collaboration with other health system actors, especially the health secretariats and the health service provider. At the beginning of this project, they were fighting. It was the public government or public institutions or private institutions. They saw the new population as a threat. They only are requesting things. And when we create something called Café Tequeño, we generate that bridge in a informal meeting, drinking coffee from Colombia. Tequeño is like a cheese stick, and talking in an informal situation. And that was important. As a result, these community-based organizations are currently invited by institutions to participate in consultations, to support the organization of enrolling section to the healthcare service for this population. So far, this activity is creating more than 9,000 Venezuela migrants getting an insurance from Colombia. That is important. Sorry that I take a little bit more time.
No, that's great. Thank you, Miguel. And I mean, I appreciate so much of what you said. And one thing that's really striking to me is recognizing that different actors come to the table with different resources and really helping build their capacity. I'm even thinking about like shared data systems or infrastructure, some of the things that really can help them build meaningful participation seems really essential. So I'm glad you raised that. We've lost Phyllis's video, so I'm not sure if we've lost Phyllis, but if there's anything else you wanted to add there, Phyllis.
Not so much. I'm here. Not so much to add. I'm listening, and I guess just to say from a disability perspective, I think the issues are so complex. There's so much stigmatization still involved, and also for historic reason, there is the issue around the medical model in disabilities. You know, there hasn't really been any voice, any participation. So some of the issues you're describing about how a process can be really equitable in a sustainable way and really lead to the results other than just having a workshop. I think the disability movement in health is even not even as far as that. You know, we don't see that participation yet. We don't see basic knowledge about disability inclusion in health amongst funders, ministries of health, all the stakeholders I mentioned. Just to give you an example, because you mentioned HIV, Jody, 30% of all HIV positive patients have a disability. This is because sometimes HIV can lead to this disability, but also because people with disability have a higher risk of contracting the disease in the first place. And funders, and we have open discussions about it, but funders like the Global Fund is one regional grant that really focused on disabilities and HIV. Out of all the billions of dollars that have been spent, there's a group that's sizable that is really not kind of part of the overall consideration. And so, yeah, I'm listening, and I'm just, I think, reflecting that I think as it relates to this population group, people with disabilities, we're even less far than some of the examples or the issues you're describing, how to sustain equity and equitable processes.
Thank you, Phyllis. And I don't know if you know, but there is a slide now from, it looks to me like understanding the systemic factors that go into, but it's a slide I think that you shared around the health systems framework. And so why don't we pivot to that, and you can talk us through a little bit about what your intention for sharing this slide and what you'd like us to get from it.
Yeah, I think in our brainstorm before this call, it came up, and just to say, I think really this tries to illustrate what are the different elements of a health system that need to change in order for health outcomes to be more equitable and fairer, access to be fairer, as Jody said in the beginning, for persons with disabilities. There is things at a system level around governance, leadership, health financing, data that need to be addressed, but then of course also at the service delivery. And all of this needs to come together and needs to be informed and designed by persons with disabilities and in participation. And yeah, I think right now we still don't have kind of critical mass of players at all levels that are interested in or that are engaged in sort of building this movement for work in critical ways to happen at all of these different levels. I think there is now a bit of a positive trajectory. The WHO has or the World Health Assembly has approved a resolution on inclusive health last year, and the WHO itself is really pushing on this topic now. So I'm hopeful, but all to say, again, the more individuals and institutions that work in health become interested in layering on a disability perspective to their work, I think the more we can achieve together. And it is still at this early stage of movement building where that is really important. So once again, I'm very happy to be here, and I hope this maybe inspires some of you to want to learn a little bit more about this topic.
Thank you. And so I'm seeing the time. We have time for, I think, one more question that I'll pose to Jody and Miguel. And so, you know, one of the things we also talk about when we're thinking about equitable outcomes is that you can't only focus at the individual level and getting access, for example, as you mentioned at the top of the hour, but really thinking about how we can move upstream to address the system and structural and organizational levers that affect equitable outcomes. And so I want to ask each of you for your reflections on how we can layer these approaches together and better influence that systems level change that we are looking for. So Jody, can I start with you?
Sure. Yeah, and I wanted to quickly respond to Phyllis, because I think just to emphasize, just sort of second what you're saying about the work that we need to be doing, particularly in global health, around a better inclusion of people with disabilities. The project that I manage has worked for the last several years with the Inclusive Development Hub at USAID and with the WHO specifically, to look at better inclusion of people with disabilities and what that means. And we did highlight persons with disabilities as a population that we've not fully addressed in our vision for health system strengthening. So I think those are good starts, but just really wanted to second that. I think this is an area that we need to explore a lot of. So really appreciate that you're here and you're on this panel, and that you bring that to our attention, because for myself, I need to learn a lot more. And I feel like the more I learn, the more I realize, we have a lot of work to do. So I appreciate your being here and calling us on that. So to your question, Jody, just want to quickly say that, I don't think, we do talk about systems in terms of levels, and I don't want to get too esoteric, but I don't think these things are different or mutually exclusive. Systems are made up of structures, organizations, and people. And so if we tried to take a system apart, it's like peeling an onion. And so the whole is greater than the sum of its parts. And it really is about the hydraulics and how how we pay attention to the inputs that we're putting into the system and how they're impacting the whole. And it's a tough change in the way of thinking, because we want to see an input, and then we want to see the evidence of the output and the outcome, and it all just makes our lives a lot more simple. But it's not actually the way the world works. We don't have this sterile environment where we can just sort of isolate factors, because we're talking about people, we're talking about different populations, different political economy factors, et cetera. So as much as it may seem complicated, A, it's not insurmountable, and B, it's not optional if we're really talking about sustainable change and really getting to the last mile of populations, or to every group that needs services. So we need to focus on how those approaches that we're taking are impacting systems beyond the immediate output. I will stop there, but just to say, I think this is just a great opportunity. And I know we probably don't have a lot of time for attendants to pose questions, but I know there's a lot of really good discussion around this that we're just getting started on today.
Yeah, absolutely. Miguel, anything you want to say there about systems change?
I completely agree with Jody and Philip. we have to be realistic sometimes. You know, that's the most important thing. We cannot come with a, as I said before, with a recipe or a magical formula to implement, because following the 1, 2, 3 sometimes cannot be the real thing to do in a different context. This is important. The other thing is optimize resources and generate that to create the high impact. And going back to be realistic, we cannot talk about access, healthcare, everything if we don't have in consideration that we are dealing with human beings, you know, and maybe something that is important for us in this position, maybe it's not as important for them. We can have the perfect hospital, we can have the perfect doctor, we have everything. But if we don't have a simple elevator for a disability person to go to the first floor to the third floor, the strategy can, you know, be a completely disaster. That's the thing. Going back to be realistic and think about other, be in the shoes of other is important.
Thanks, Miguel. Okay, I'm looking at the time. I'm just wondering if any of you, where I had wanted to go with the next question was like just ending on a really hopeful, inspiring, optimistic note of even just a small win that one of you has seen, experienced. I don't know, that we all made it to this webinar. It's a small win. I certainly see it as a big win to have learned from you today, but just wondering if anybody wants to leave us with something inspiring.
I don't know if it's inspiring, and I certainly don't need to be the last person to speak, but from a sort of a 40, 30, 40,000 foot perspective, and this is going to make me feel old, but I mean, I've been working in health systems for over 20 years, or about 20 years. And I think we get so focused, as we should, on the next step and where we're going and what needs work. And but I also, we always talk about in this field, it's a marathon, not a race. And so I think it's always important to sort of step back and look at how far we've come. Because I will tell you, when I first started working in health systems and first started talking about equity, one of the stories I tell is that the first time I ever, sort of did a workshop, and I was naive, I was still in grad school, I was like, oh, I'm just going to love this, it's going to change the world. And it was a half-day workshop about, health systems and why we need to invest in things for better access and better healthcare. And I think I probably talked for 5 minutes, because the entire time I was getting feedback from people about why this wasn't a good idea. I didn't know what I was talking about. It wasn't going to, because people just didn't understand it. And I was surprised. I was shocked. I thought, oh my God, I really messed this up. But it was a lesson in listening because what I was hearing was really critical, and it was frustration from people saying, like, we're inundated, we're drowning, and now you're coming at us with another thing that we have to do, right? So I would say that I've seen so much progress and such a big learning curve, not just on the healthcare worker side, on the policy side, but on increased literacy of people who are achieving healthcare. And I don't think that in any way means we should slow down and revel in that. We have so much work to do, but this is in and of itself a process that we're all learning from in it. And every year that I do this, I see such amazing progress. Whether it's community health and people getting involved in the governance of their health system, their healthcare, or as Miguel is talking about, sharing how Colombia has pivoted from being having people leave to now they're a country taking in migrants, and how they've pivoted. I mean, this is a huge struggle, but these are all really encouraging. And and I love having people, talking with people like Miguel and Phyllis, and really seeing the work that they're actually, making it happen, because it sometimes I think we are so incremental processes and development happens so, sort of it feels like it's glacial, that we forget that we have made some tremendous progress and really moving towards good health systems. I'll stop there.
I love that. It's a wonderful place to stop. So just thanks to everybody who participated. I know we're a couple minutes late. We will be hosting another webinar on February 29th, which will be co-hosted with the Frontline Health Workers Coalition. So thank you to all of the panelists. This has been fantastic. And thanks for your time. Thanks for everybody who listened in, and best to all.
Thank you.